Okay, Assalamualaikum everyone. Can you listen to my voice?
Waalaikumsalam, saya boleh dengar.
Right. Okay. Thank you very much. Sorry for the technical problem just now. Let me share the slide for you to have a look. Okay. Okay, while waiting for me to settle the technical problems, can you just quickly fill in your e-attendance through UFuture? And this session is recorded, so a recorded video will be uploaded onto UFuture or being shared with the class rep, right? Okay, now can you listen to my voice? You can, right?
Yes.
Can,
Yes.
can you see the screen in a full mode? Can you see my PowerPoint slide in a full mode? Is it? Arif?
No, it's in a edit form.
Okay, dalam edit form. Okay.
Uh,
Well, I cannot find the button. Can someone please help me? Maybe Arif. Arif, I'll send the lecture slide. Okay, to your WhatsApp, and then can you just share through your account? I don't know
Uh,
why this is not working. Okay, sure.
sir, this is clear too.
Pardon?
We can see the slide clearly. It's okay.
Clearly. Okay, you can see.
Yes.
Okay, even though in this mode.
Yes.
Oh, all right. Okay, if that the case, then we just proceed with the lecture done. All right. Okay, so today we are going to have the first lecture on PHC 690, where the first chapter will be something to do with the psychiatry. Okay, so the first topic is bipolar disorder mania, or bipolar affective disorder. Sometimes they just call it manic patient. Okay, even though some of the patient might have depression. Okay, so for the very first lecture, we will cover both mania and MDD as well. Okay, which is major depressive disorder. All right. Okay, so let's have a look at the references. Okay, so we have DPRO, and then we also have applied therapeutics. You can also use a CPG for bipolar affective disorder, as well as the major depressive disorder, or major depression, all right, as your main reference. Okay, what are the learning objectives? You can have a look at these three, and it is self-explanatory. So let's begin with the first one, which is bipolar disorder, or simply mania. All right. Okay. So I believe that you have encountered these fictional characters in your daily life. Okay. Maybe you love to watch Saturday morning cartoons back in the days. Okay. So we have in the world of Warner Bros. Okay. If I'm not mistaken. So we have Harley Quinns. Okay. We have Jokers. Okay. And these two characters has been portrayed to have somewhat very distinct characteristic. For example, a Joker can be very sad at one moment, and at one time he also can be very happy. So this is more or less like bipolar, because mania is something that you are very happy, while whenever you have depression cycle, then you might have what we call it very deep sadness. Okay. However, uh, based on these two characters, okay, they are not considered to have bipolar, because the act or behavior that they had is actually more or less like what we call it psychopath. Okay, so this is not bipolar disorder, but what we can know is actually bipolar is a common, lifelong, and severe cyclic mood disorder. Cyclic meaning to say that it keeps on changing between moods. Okay, moods can be very sad, which is depression, and can be very happy, which is mania. Okay, so it will be cyclical disorder. Okay, where the moods change from happy to sad, and then happy to sad throughout the life. Okay, so these can be also characterized by fluctuation in mood, energy, okay, and behavior. And also, in order to be considered someone to have bipolar, you should not have mania or hypomania, which is due to other substance use, for example, drugs or chemical substance, or even activities, right? So it must be caused by, you know, through psychiatric disorder before we diagnose as bipolar. Okay, so I believe that this fictional character is not a good example, but in real life we do have some celebrity that have bipolar affective disorder. How many of you know these people? Well, the Mariah Carey, okay, fans could be very sad to know that she is actually having bipolar. And then these the 90s actors from Hollywood, okay, Jean-Claude Van Damme and Catherine Zeta-Jones, they also have bipolar affective disorders. But in Malaysia, you can look at the picture that we do have some popular artists that have what we call it bipolar. Okay, I believe that most of you know these three people. Okay, so I don't want to speak more about this. I'm afraid that I could be summoned. Okay, or even have to go to the court. Okay, whenever I review their names. Okay, so this is a little bit taboo in Malaysia. Right. So, like I said, cyclical disorder is actually like switching between mania and depression. Okay, And in some cases, we do have hypomania because we have two types of bipolar, type 1 and type 2, and they are different. The problem is that some might have what we call it a normal mood, okay, just like normal people. So throughout the life, okay, at one point they will have normal, and then they might have hypomania, and then they go deep to the depression, and then they go up to mania, happy again, and then a little bit depression, okay, and then they might have both mix, okay, hypomania and subthreshold depression, and then so on, okay. But remember, this is not happening in one particular person, okay. It depends on the type of bipolar affective disorder itself, okay. So it could be hypomania and severe depression only, okay. It could be very normal for 1 or 2 years, okay, or it could be a very fast cyclics, okay, or changes between mania and depression, okay. So this is like a graph to show how the cyclic disorder happen in one particular bipolar affective disorder patient. Okay, if you look at the pathophysiology, more or less, it is actually derived from the genetics, okay? It also, because of neurobiological, and then some might also affected by psychological factors, okay? Could be, the childhood is very traumatic, okay? Or even father or mother might have the same psychiatric disorders, okay? Other than that, some medical condition might also induce mania, like the one that being listed in the table. And then some medication most probably will be those from, illicit drugs, okay? Or even some prescription and non-prescription drugs, okay? In fact, psychiatric medication can also cause induce mania. And some somatic therapy, like for example, bright light therapy, deep brain stimulation, and sleep deprivation can also induce mania, okay? But this is actually to induce mania, okay? For depression, you can guess that a lot of activities also can contribute to depression, like for example, having a wrong friends, okay? And then you have a traumatic life experience and whatnot. All right. So these will be the pathophysiology of mania. So how does the patient with bipolar affective present to our clinics or even hospital? Basically, they will have what we call it different type of episode sequentially, or with or without a normal mood, okay, or euthymia, okay. And that is actually sometimes they just have mania, depression without any normal mood, okay. And these can be mood fluctuation that continue for months, okay, or after one episode. So it should not be, every years or every day they have mood swing, right? So this is like boring, okay? This is very enjoyable, and then this is actually, quite out of normal, and then this is like, very happy. So the mood is actually range from this until this, okay? So we will look at the more detail about the symptoms. All right. So whenever we want to say that the patient have manic, okay, or mania, they will have what we call it elevated or expansive mood. Meaning to say they are very happy. You see rainbows, music, okay, and then the sun is rising, okay, and then usually we will feel more happy, okay, to have all this because we enjoy music and whatnot. And at one point, it can be represented by, with cloudy weather, okay. For example, irritable mood, okay. Usually some people might have irritable mood whenever we have cloudy season, okay, especially in the case of four season country, okay, like in the UK or Scandinavian country, they have winter and a lot of people are having depression at that time. So this is actually representing depression, and this one is mania, right? So it could be either one. They must have these two. And then apart from these two, they also have to have what we call it here, okay? Inflated self-esteem and grandiosity, meaning to say they suddenly they feel that they are the king of Malaysia, okay, or even the CEO of a big multinational company. Okay, and then they started to be very productive, overly productive. Okay, meaning to say that they start not to sleep. Okay, in fact, they are doing a lot of their passionate jobs. Okay, that could be what we call it increased goal-directed activity or even agitated. Okay, agitated means to say they keep on scolding people and then get angry easily. Okay, and then at one point they also like to take risks, okay, for many, unexplained reason. Okay, for example, suddenly you want to go for bungee jumping, okay, and then do some risk activities that could be indicating that you have mania. And because of you are very productive and start to feel, overproductive, you start to have what we call it decreased sleep. Okay, and then you cannot focus, then you talk more, okay, or talkative with pressured speech, meaning to say that you speak very fast, and in your head you have a lot of ideas. Okay, but it keep on changing from one topic to one topic, okay, which is very very different. All right. Okay. So like I mentioned previously, bipolar have two types, so type 1 and type 2. For type 1, this one, okay, you will have mania. However, for type 2, you have hypomania. Okay. So what would be the difference between mania and hypomania? We will have a look at this later. All right. So in the continuum disease model, okay, for bipolar, okay, this one is schizophrenia. Okay, this is schizophrenia. This is mood disorder. Remember, bipolar is mood disorder, and it fall in this between this. Okay, so basically, your bipolar will be depression and what we call it and mania. Okay, so in this case, bipolar will be somewhere in here. Okay, here, right, or here. Okay, how do we diagnose people with bipolar? Okay, first thing first, we look at the number of episode. Okay, for bipolar 1, there must be one manic episode, and this is actually based on DSM-5, okay, or the latest one will be text revision or TR. So bipolar 1, you have one manic episode, and then maybe have or followed by hypomanic, okay, or major depression. For type 2, you have at least one hypomanic, okay, and then followed by major depression. Okay, so this is actually to distinguish between the types. Okay, so remember type 2, they have hypomanic. Okay, type 1 is the ordinary one, which is mania. And then we also have others, diagnoses like cyclothymic disorders, okay, and then unspecified or specified, okay, but this one is not our focus for today. Okay, like I mentioned earlier, this is bipolar. Remember, bipolar is mania, so it will be having full swing of mania as compared to bipolar, which is a little bit lower, okay, because hypomania, okay, so there will be like a little bit reduced in peak. So that is actually bipolar, while that depression is actually going down straight away. So this area is depression, this area is mania. Okay, let's have a look at the bipolar type 1, okay. So remember, mania occurs and then it will be normal. This is normal line, okay. And then at one point, the patient has mania and then normal, and then mania again. Okay, this one is actually mixed, yeah, together with the depression. Okay, so it will be represented by rainbow, sunshine, and then music, and then for depression, a little bit depression here, and then severe depression. Okay, so it will be represented by cloudy weather. Okay, this is type 2. Remember, hypomania. So it's a little bit reduced in peak, okay, as compared to here. Okay, and then the patient might have depression first and then start to have mania for certain, months or years. Okay, how do we diagnose? Okay, again, like I mentioned earlier, it is based on DSM-5 criteria or DSM-5 tech revision, which is the latest revised diagnostic criteria. But this table is actually a very self-explanatory. Whenever you have all these, symptoms and terms that being described by the family members or even the patient itself, Okay, so you will start to tick and then you start to analyze which of mood disorder that the patient is having right now. Okay, so usually the psychiatry will do all the diagnosis. Okay, they take medication, medical history, physical examination. Some do blood testing, and then some also speak to the family members because sometimes psychiatric patient they might need, they might not telling everything, but those who are living with this psychiatric patient might also contribute to information, okay, contribute the information to the psychiatry to better understand the situation. Okay, for example, delusion, hallucination, and suicide attempt could be the more common in bipolar, okay, than unipolar depression. Unipolar depression meaning to say that he or she doesn't have mania, okay, meaning to say that true depression. Okay, and then acute mania usually begin abruptly, okay, and then it will start to mark impairment in functioning, meaning to say that whenever you feel mania, okay, or you feel happy, you start to ignore your maybe responsibility as a student, family, okay, to the family or to maybe your students, okay. If you are a teacher, then that could be what we call it impaired social functioning. Remember, you are allowed to be happy, but as long as it is not impact your social functioning. Okay, hypomania. This is the difference between mania and hypomania. There is no marked impairment. It's still happy, but productive than usual. Okay, that is only the difference. Okay, mania and hypomania, one have impact functioning and one doesn't have. Right. So in this cartoon, okay, you can see that we have a scale, okay, from 0 to 100, where whenever you have close to 100, okay, it will call dangerous, okay, mood, okay, and then if you have less than maybe 25, it could be problematic here. So human can feel or can have mood from 0 to 100, okay, where 0 will be boring, okay, mundane and whatnot, okay, and 100 will be full mania, okay. So normal people will have this, non-blackened scale, okay. So where you have balanced life, okay, balanced mood, okay. Sometimes you will feel very creative, okay, but not too creative until you start to be out of controls, okay, and then you also still can enjoy people, okay, where you can maintain your social functioning. All right, okay, if you refer to DSM-5, okay, TR, you will see a lot more, sub-diagnosis of these kind of mood disorders, okay, but we won't cover everything because it's too complicated for your level. However, for bipolar, you can always go for bipolar 1 or bipolar 2. And as I mentioned earlier, there will be like hypomanic disorder or cyclothymic, and it will be a lot more specifiers, like, for example, seasonal pattern, peripartum onset, psychotic features, and catatonia. All right. Okay, so cause of illness for bipolar, usually it will be childhood onset. Okay, those with childhood onset will be have more mood episode and rapid cycling, and comorbid psychiatric condition, and then rapid cycler. Okay, meaning to say that those who are switching between depression and mania very fast. Okay, 20% will have what we call it 4 or more episode per year. All right. And then rapid cycling usually associated with frequent and severe episode of depression and poor long-term prognosis. Meaning to say that slow cycler is much safer, okay, as compared to rapid cycler. Okay, women are more likely to have depression, while for men they will have more mania. And then suicide attempt, 50% of bipolar will do suicidal attempt, okay? And 10 to 19% bipolar 1 usually commit suicide, okay? Meaning to say that bipolar 2 might have higher rate of suicide because usually they will take more, what we call it, dangerous approach, okay, in order to kill themselves. Okay, in this case, what I mean is that those bipolar 2, okay, you whenever they want to kill themselves, okay, they use a much fatal approach as compared to bipolar 1, okay. All right. Okay, so let's have a look at the treatment, non-pharmacological first, okay? So these are the treatment goal, okay? Very self-explanatory, okay? And then for non-pharmacological, you can always do patient education. Family members also indicated here. And then other than that, educate nutrition, sleep, exercise, stress reduction, and so on. And for the psychological part, okay, where we involve clinical psychologists, you can use CBT, okay, you can use this rhythm therapy, psychoeducation, and then focus therapy, as well as relapse prevention, okay, with individual psychoeducation. All right. So in this case, we are not directly involved because usually psychiatry and clinical psychologists only play their roles, okay, for the non-pharmacological. But the more important part will be the pharmacological therapy, okay, which our roles would be more important, all right? So this is the algorithm of treatment for treating acute and refractory. Refractory meaning to say that they have been treated before, but now it relapse, start to produce the same psychiatry symptoms, right? So this is also similar. Okay, which drugs to use would be depend on the diagnosis. Okay, for example, if you have acute mania and mixed episode, okay, usually we will look at the secondary cause of that symptoms first, and then if the patient on antidepressant, you have to discontinue, and then you also have to look at the other stimulants or even drugs abuse, right? As well as the nutrition. And then whenever you have hypomania, okay, so it will be, most of the time psychiatry disorders, okay, they have patient that non-compliance to medication. So in this case, you have to look at the compliance of the patient to that medication, because if they do not take the medication, the symptoms may appear. Okay, so that could be the first thing that we have to do. If not, then we'll look at or maybe change to other medication so that the patient can be normal again. Okay, so this is self-explanatory. You can have a look later on, but what I want to really focus for today will be the pharmacological therapy for bipolar affective disorders. Okay, so whenever you have mania, you have to give lithium carbonate. Okay, so that is actually a mood stabilizer. Other than that, you can always use anticonvulsant, like for example, lamotrigine, carbamazepine, oxcarbazepine, okay, and whatnot. Okay, VPA is also can be used for this case, and you can start with 300 milligram twice daily, and then you adjust based on the TDM results. Okay, because most of the medication that used for bipolar is actually neurotherapeutic index, right? Okay, the other things that you need to monitor will be, the side effects of this medication, because the medication itself has notorious side effects. For example, it can cause metabolic, problems like obesity, and then rashes, and then start to, destroy your kidney or liver, as well as make your electrolytes in balance. Okay, so SGA, or what we call it, second generation antipsychotics. Okay, before you start, you have to do all these baseline physical examination and general lab investigation or chemistry. Okay, all the complete blood count, uh, and so on. Okay, for all. And then for SGA alone, okay, you have to make sure that the patient undergo metabolic test. Okay, and then same goes to lithium as well as valproate. Okay, and so on. Okay, for most of the medication, they can cause rash. Okay, therefore you have to do some dermatologic assessment. All right. Okay, so Other than that, okay, remember, like I mentioned previously, most of the medication are in oral form, in tablets, okay? And in some cases, patient reluctant to take the medication because they don't believe that they have such psychiatric disorder in the first place. So in this case, we can always opt for long-acting injectables, meaning to say that the compliance issue is no longer there, okay? But the patient must come to the psychiatric clinic to get the injection, okay, administered by the psychiatrist or nurse. So in this case, whenever you have a very difficult patient to handle and a very non-compliance one, okay, always opt for LAI or long-acting injectables, okay. So it can be fluphenazine, haloperidol, risperidone, paliperidone, and aripiprazole and whatnot, olanzapine as well. So these will be the pharmacokinetics parameters for each, okay, where is the time to peak, okay, and then half-life, okay. So you can see that the half-life is actually very long. We need to say that whenever they have that injection, it could last maybe up to 1 month or more. Okay, so they don't have to take the medication every day. Thus, it will improve the compliance. Okay, so remember, psychiatry can occur in all walks of life. Okay, in the case of pregnancy, okay, because lithium will be very, teratogenics, okay? So it can cause what we call it Epstein anomaly in an infant, okay? Whenever a pregnant woman take lithium. Remember, medication cannot be stopped even though you are pregnant, okay? So it would be very risky for some of the population, okay, to use anti-manic or mood stabilizer in the first place. Other than that, lithium can also cause risk of neural tube defects, okay? And then whenever you have pregnant bipolar patient, okay, please use lithium at the lowest effective dose, okay? So that could be one of the things that you can do in order to make sure that the pregnancy is safe, the baby is safe, as well as the patient is improving to normal. Okay, and then you have to monitor closely and adjust the dose. And in the case of breastfeeding mothers, usually we don't encourage them to breastfeed whenever they take lithium. The other alternative is to use formula milks or to have somebody else to breastfeed. Okay, and then like I mentioned earlier, other than lithium and VPA, we also have other anticonvulsant, okay, as a mood stabilizer like valproate, carbamazepine, and lamotrigine. And this is actually also notorious for pregnant women because it can cause neural tube defects in babies where you have to give folic acid, okay, in order to counteract, okay, or minimize the effects of on the fetus, okay. And then women taking valproate can breastfeed, okay, but mother and infant should have what we call it TDM monitoring. Okay, so that would be the things that we have to consider. Okay, in the case where you prescribe FGA or first generation antipsychotic, there will be like little teratogenic risk during pregnancy, but whenever you want to use FGA or SGA, it will be much more limited. Okay, whatever it is, SGA will be much better than FGA. Okay, so you have to check the teratogenicity of each medication before you start the medication. Okay, in people with bipolar, which is a child or children, okay, you can use, okay, lithium, VPA, and carbamazepine. Okay, for teenagers, you can use aripiprazole and risperidone. Okay, for this age, you can use quetiapine, and for this age, you can always use olanzapine. Okay, so you have to avoid some medication that contraindicated in small children. And lastly, lithium, okay, which is mood stabilizer, must be used for children older than 12 years old. And then you also have to use practice parameter, okay, whenever you treat children and adults with bipolar. And remember, half-life of lithium and valproate increase with age. Okay, the older it will have what we call it increased sensitivity to side effect of lithium. Okay, so lithium, the side effect will be, hyponatremia. Okay, and then in some cases they also have rash. Okay, to some of the cases, right? So you already have patient with bipolar, okay, and then you also have what we call it um, uh, what are the causes of the bipolar itself. Okay, we have learned about the treatment. The main is actually mood stabilizer to treat the depression. Okay, and also we have checked the special population where or which of the treatment is valuable for them. Okay, now whenever you want to evaluate the therapeutic outcomes, okay, you have to make sure that the patient document all the symptoms, when, how many times mania, how many times depression. Okay, it daily mood chart. Okay, so usually the psychiatrist will require the patient to have a diary. Okay, to record for all the symptoms every day. And then as a pharmacist, we also have to assess medication adherence. Remember, psychiatric patient usually will have what we call it problem with adherence. And then we also have to ask the patient whether they have all the, standard adverse effects for each medication, like for example, sedation or even weight gain. Okay, so that could be indicating that the patient have severe side effects of the long-term treatment. And then remember, they also have to record whether they attempt or they have an idea of killing themselves. Okay, so this is quite sensitive issue, but suicidal completion rate for bipolar 1 will be 10 to 15. Okay, and then suicide attempt primarily associated with depression. Okay, rather than mania. Okay, and then it could be also because of psychosis. Psychosis meaning to say that they start to hear something, in the brain telling them to kill themselves. Okay, and then we can always come up with two results whenever the patient has completed the treatment, whether it is partial treatment response or non-response. In this case, you have to, change the medication or do some others non-pharmacological therapy. Okay, or add on. Okay, so that you can control the symptoms, and then always involve patient and their families. And in most of the time, we will use what we call it standardized rating scale. Okay, like for example, whenever you have pain, okay, the doctor will come up with a pain scale, right? So in this case, in bipolar, mania, or even depression, we do have some kind of like, survey question where we will start to give ratings, okay, for each individual patient. Okay, so that could be the things that we do for monitoring for deep bipolar disorders. Okay, to get more information about how to treat this bipolar, you are advised to read CPG. Okay, especially the key points. Okay, so let's have a look. In general, okay, in Malaysia, okay, we establish diagnosis of bipolar, and then we assess severity, and then we decide the treatment, whether inpatient, outpatient, or community. Usually inpatient warded whenever they are very aggressive. Okay, if they are friendly, they are just normal people, then we just treat them outpatient or even at community or pusat kesihatan. Okay, and we start the treatment. Okay, whether we would like to have injection or even oral tablets. Remember, rating scale is very important. So we have Young Mania rating scale as our monitoring system. Hamilton for depression. Madras, okay? Madras is actually for the depression as well, okay? So usually in HASA, we use Madras. But in the US or Canada, they use Hamilton rating scale. But these two are more or less similar, right? So if you look at the treatment algorithm here, okay, whenever you have acute mania meaning to say that it comes suddenly, okay, abruptly. You have mania and then you start to feel happy. You take risks, okay. You want to do bungee jumping, okay, and whatnot. So you always start with one single medication or monotherapy, either lithium, valproate, and carbamazepine, okay. start with this first. Okay. Or now you start lithium and then patient partially respond or not respond. Okay, so you move to the second group, which is haloperidol, atypical, or antipsychotic. Or you can always switch to valproate or carbamazepine. Okay, first. If all these three fail, then you move here and then you do combination. Okay, so it will be like sequential. Then if no response within 2 weeks, okay, you can always go to step two where you add or switch, okay, based on this, recommendation. And then you do some assessment 2 weekly, okay, and then you do for step three, okay, whenever everything is fail, okay. Remember, it must come together with electric brain, electroconvulsive therapy, okay, and then it will also comes with psychosocial intervention, okay, where psychologists come into play. All right. So this one is like giving electric to your brain. Okay. So you can use whatever, but the problem with ECT is actually they will have what we call it temporary memory loss. Okay, that is the only problem. For psychosocial, it's just a talk therapy. It could be helpful, it could be useless. Okay, but again, we recommend along with the pharmacological therapy, you have to use non-pharmacological therapy as well. All right. Okay. So whenever you have acute depression, remember lithium is also one of the medication. You can use either one, quetiapine, or you would like to have combination. You can lithium and valproate and so on. Okay. After 2 weeks, you do assessment. If still non respond or partial respond, then you start to switch to valproate and lurasidone. Okay, or you can use combination. After 2 weeks, okay, you do step three where you have to do all this, monotherapy or combination therapy. Pick either one, okay. But again, together ECT and psychosocial. Okay, this is the flow chart of patient with pregnancy. Okay, whenever they have bipolar, it will be very straightforward. Remember, we have to treat based on the pregnancy duration. Okay, for the pre-gravid. Okay, pre-gravid meaning to say that before plan to pregnant. Okay. So we have to discuss with them. Okay, and then look at the flowchart. Okay, if yes, then taper off medication. Okay, if no, then continue treatment. Right. And then for those who are already pregnant, okay, if first three semester, month one, month two, and month three, okay, if yes, then you have to do all this stuff. If no, which is a second and three semester, then you have to continue to the same medication. Okay, so this is like how to do the switching or even changes whenever you have pregnant patient. All right. Okay, so that's all about the bipolar. Can we have maybe okay, we have another 10 minutes. Okay, let's continue with major depression. Okay, major depression. Okay, major depression is actually part of bipolar. Okay, but some people might not have mania, so they only left with depression. So we call it major depression. So major depression is one or more depressive episode without history of mania and hypomania. Okay. Well, it is actually due to a lot of theories. Okay. Chemical theories, okay, neuroactive, steroid, and whatnot. Okay, a lot of hypotheses, but you don't have to memorize all. Okay, this is just showing that it's still debatable. Okay, in terms of what caused depression. Okay, so whenever you have depression, okay, usually you can see depression among students as well, especially during exam weeks. Okay, so those with depression, they will have what we call it emotional, physical, cognitive, and psychomotor symptoms. Okay, emotional meaning to say that they have sadness, pessimism, okay, crying, hopeless, anxiety, guilt, okay, psycho features, okay, psychotic features, start to hear things, okay, or even seeing things. All right. So hallucination is actually, uh, it's like, you see things or you hear things. All right. Delusion is your false perception. Okay? The best example is you start to, to believe that alien is actually coming to the earth and invading the world. All right. So hallucination, you could see, stars, okay, lingering in your room. Okay, that could be what we call it hallucination. Or maybe you can always listen to male or female voices, okay, in your ear, telling you some things that very unusual. Okay, so that would be hallucination. And then to some extent, depression also can have suicidal ideation. So we have to help this kind of people. And then other than emotional, physical, usually they will either lose the weight or even gain. Okay, and then always fatigue. Sometimes they have headaches and then cannot sleep. Okay, don't want to eat and sometimes eat too much. Okay, and then loss of libido. Okay, and most of the time will be constipation as well as palpitation, right? And in the university student cases, okay, we found that those with depression, they will have cognitive symptoms, okay, where they cannot focus, they cannot remember whatever they learn, and then they start to confuse and even poorly perform in the final exam. And those with psychomotor, they usually will be having physical movement because they're fatigued, so they will move slowly, and then also slow thinking as well as speech. And then sometimes they will have what we call it agitation. Agitation means the shaking, okay, shaking hands or limbs. So that could be telling you that the patient is have or the person is having major depression. Like in mania, okay, we have depressed mood, okay, but don't have the rainbow, sunshine, and musics, okay, but they have loss of interest. You see a rabbit here, don't have any interest toward carrot, okay, because they like carrots, okay. So and then weight gain or weight change, okay, sleep disturbance, cannot sleep, and then agitation, keep on, scolding people, angry, okay, or even not functioning at all, okay, doesn't talk whenever other people are talking to him or her, and then always fatigue, okay, always feel worthlessness and guilt, okay, and then poor academic performance, or even want to kill themselves, right? So in the graph, okay, it can be in the 2U shape, okay? This is depression, this is mania, hypomania. So they basically would do here, but in bipolar, they will be like switching, right? You still remember switching, okay? And then diagnosis, we do this diagnosis criteria based on the DSM-5, okay? So it will be abbreviated with CG caps, okay? Suicidal, interest, guilt, okay? Energy decrease, concentration, appetite, psychomotor, and sleep. And at least 2 weeks, okay? You have to look at the symptoms, okay? So this is CG caps, okay? And again, the scales, okay? Those this is you see this is a rope where the person would like to hang himself, okay, so this will be the depression. This is very, don't have any feelings, so apathy, okay, doesn't want to give donation to poor people, okay, doesn't feel anything, okay, it will be problematic. But whenever you have depression, it will be very dangerous. So normal people will fall in between of these two. All right, treatment. This is the treatment goal, okay? And the non-pharmacological treatment will be a part of the whole treatment for depression. Like again, in the psychology area, okay, we do psychotherapy, and then we also have ECT, where we put current, okay, electrical current on your brain. This is psychotherapy, where clinical psychologists will talk to the patient. And then in some cases, we also have transcranial magnetic stimulation, okay, or similar to ECT, but now we use magnet, okay. Okay, and then we also encourage the people or the depressive people to do exercise, okay, because exercise will help to release endorphin, happy hormones, and whatnot. So in the case of major depression, okay, it will be individualized treatment. Okay, adherence again a major problem. For acute episode, medication can be added or even tapered down. Okay, and in bipolar, we have to put the patient on mood stabilizer lifelong. Okay, and then this is the algorithm of treatment for MDD. Okay, in the case of bipolar, we use lithium, right? But in the depression, we use SSRI as the first choice. Okay, and then you start to change and switch to non-SSRI whenever the patient react abnormally, right? What are the drugs? Okay, antidepressant medication that we use, citalopram. This is SSRI, which is the mainstay treatment for depression, major depression. Escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. Other than that, if the patient cannot tolerate to SSRI, you use SNRI, or even not respond to SSRI, you switch to SNRI. Other than that, we also have option with TCA, but TCA would be much more notorious in terms of side effects. We also have others whenever everything is failed. And lastly, these will be the dosing, okay, for some others non-popular medication groups, okay. All right, okay. So what are the side effects? Okay. Well, they have a lot of side effects. Okay, and it is actually based on receptors. Okay, we have serotonin, M1, H1 histamine 1, okay, alpha 1, or even norepinephrine. Okay, so for each group, they have what we call it some kind of pattern. Okay, where they inhibit. Okay, so this is actually the blockade. Okay, whenever you see 4 plus, meaning to say they are strong inhibitors. So citalopram, all these SSRI will inhibit mainly on here and some here. But SNRI will have both, okay, but a few here. And TCA will have a lot of things. Therefore, they have what we call it notorious side effects, okay. And then for this, it will be a little bit scattered. Same goes to the rest of the group, okay. So usually when you have all these medication, they are actually anticholinergic. Okay, so anticholinergic side effects will be dry mouth, blurred vision, okay, and then urinary retention and whatnot. So that will be things that you have to monitor whenever the patient start to take this kind of medication. All right. Okay. So, well, this is the ADR and monitoring parameters. Okay. For each group, you have to look for the ADR and then monitor accordingly. And there will be like some, a special instruction whenever you want to use this thing. Okay. Particularly in the case of age or gender or even risk patient. Okay. So for each, you have to be very careful before you start the medication. Okay. So other than that, we have what we call it second and third generation antidepressant. Okay, these will be the much more what we call it latest drug. They inhibit certain enzyme in the liver. Okay, so you can see that they can interact between each other, and you have to also aware some of the pharmacokinetics, pharmacodynamics parameters here. And these are the dietary and medication restriction whenever you take a MAO, okay, or monoamine oxidase. So do not advise the patient to take this medication whenever they take the medication, okay? Otherwise, it will be interacting each other. So for special population, you can read on your own. Okay, so this one you can get from the textbook. And lastly, to evaluate the treatment, you have to do all these stuff. Okay, monitor blood pressure. Okay, do the blood checking, and then of course you also have to check the diary from the psychiatrist as well. Okay, so this will be the monitoring that I shown previously, and you can learn more from the CPG of Malaysian. Okay, MDD. Read for the key points here. Okay, it's more or less similar to bipolar affective disorders. Okay, but it will be much different in terms of selection of drugs. Okay, so the most important part is that if you have mild and moderate, then you can always start with non-drug first. Okay, only you have moderate to severe, then you have to what we call it, start the medication straight away. All right. Okay. So that is actually the things about major depressive disorder. With that, I will say thank you, and I'll see you in tutorial later on, okay, for the case. If you have any questions, okay, please put in the chat box. If no, then we can end the session. You can always ask me later through your future. All right. Okay. Thank you, everyone. I believe that you have class. Do you have class? Anyone?
No.
You don't have class.
Yes.
All right. Okay. If that the case, then I would like to take the question from the floors. Okay. You can put your question in the chat box. If no question, then we will end the lectures. Anyone would like to ask?
Sir, one
Yeah.
question, sir.
Yes.
So if he was experiencing manic, so he would take the mood stabilizer, and if he experienced depression, then he can take the mood stabilizer too. So it can be the same drug lah. For
Yes,
example, lithium for manic and lithium for depression.
that's correct. That's correct. Unless the depression is not well controlled, then you have to switch to another additional drugs. Okay, so you have to play around with the medication. In this case, whenever the patient, remember, whenever you have mania, you take lithium, right? And then you take lithium, and then at one point the patient start to have depression, right? So remember, when you add antidepressant, okay, so you will take combination lithium and antidepressant medication in order to counteract the depression. And then the patient start to have mania again. But whenever they have that stage, okay, or they feel mania, okay, you have to stop antidepressant because antidepressant medication can cause mania. So that is the most important take-home message that you have to learn from this. Okay, any other question? Did I answer your question, Munir?
Yes, sir. But antidepressant can cause manic. So what are the proper counseling, sir?
The first thing is actually to, whenever the patient is having mania now, okay, just resolve with depression. Now comes with mania. Stop that antidepressant because it will be useless, or in fact, it will be, make it severe for mania. So usually we don't. Of course, we will give psychology therapy, okay, in this case, but antidepressant will not help in mania stage. Okay, so you better to stop. In fact, the patient is also happy because he or she will take less medication. Okay, did I answer your
Thank
question?
you, sir. Yes, yes.
All right. Okay, what are the other questions, please? So, do bipolar patient tends to become violent? Yes, in the case of mania, okay, it will become violence, okay, sometime, but not as severe as psychosis, okay, or schizophrenia. Bipolar basically will be much more dangerous to themselves, okay, aggressive in the terms of they are too productive, okay, and it is not as severe as schizophrenia, but you will see a lot of schizophrenia patients become violent. But that doesn't mean that they are not aggressive. Yeah. Did I answer your question, Liana Suraya? All right. Okay. So, but remember, bipolar type 2, they will have much more successful completion of killing themselves because they will take a much aggressive approach. In this case, usually people, they want to kill themselves. Sometimes they just take pills like Panadol, okay, more than 8 tablets, but it doesn't really kill themselves, okay? They just, play around with people, okay, especially those in depression mood, all right? But in bipolar type 2, they will take a much more what we call it notorious approach. Like for example, they will maybe take gun, okay, and then kill themselves using gun. because a gunshot will be much more successful in terms of killing themselves. Okay, as compared to taking, make incision using knife. Okay, it doesn't really, kill themselves on the spot, but the head gunshot will be much more, what we call it, mortal or fatal. Okay, that is really differentiate between type 1 and type 2. Sir, can MDD transition to BD over the time? Nurul Najiha. Well, this is a good question because during the first year or few first year, psychiatrists might have difficulty in terms of categorizing bipolar disorders. Because, like I mentioned earlier, the cyclics between depression and mania could be very long. Okay, maybe for the first 3 years, the psychiatrist may initially diagnose that particular person to have major depression. But after 3 years, okay, the patient develop mania. Then at that point, only psychiatry can know that the patient is having bipolar. So it depends on which symptoms come first. Okay, usually it will be mania first, but in some cases it will be what we call it depression. So to answer Nurul Najiha question, yes, MDD can transition into BD provided that the patient develop mania afterwards. Did I answer your question, Nurul Najiha? All right. Okay, good. Who else would like to ask? This is a very interesting question. You don't have to worry. You can always learn later on. You can ask whatever question. Sir, is high functioning depression exist? Yes, it is. Okay. Well, sometimes that particular person cannot understand or even aware that they are having high functioning depression. Okay. Well, depression itself doesn't have to be what we call it bad at all. Okay, but high functioning depression is something that usually underdiagnosed. Okay, in this case the patient is actually having depression, but they try to compensate themselves by doing a lot more productive, because depression usually will be something related to bad things, right? Okay, some people say that patient with depression might be a lazy person because they don't want to do things. They just lie on the bed, okay, isolating themselves. Well, this is actually a very typical, what we call it, I would say, assumption by publics to psychiatry or depressed people. Well, high functioning depression is actually something that very vague, okay? But this is actually underdiagnosed situation where even though the patient is having depression, but they still can be very productive. But the problem will be at the end of the period of that symptom, the patient might have a very fatigue, could be, need helps in terms of treatment, okay, afterwards, because it will start to affect the social functioning and whatnot. Okay, so did I answer your question, Muhammad Arif? You will see that some people might have high functioning depression among the students as well as some working adults. All right. Okay. So Azhar asks, is ECT still used as therapy this day? Yes, it is. Okay. I heard it is not good for some. Yes, it is not good for some, but it is good for somebody else. So in HASA, we do have electrical convulsion therapy, where they will put two poles of the electrics to the brain and put the electric currents, okay, so that it will be like rewire back all the electrical conduction in the brain. Okay, so it's like resetting your brain. Okay, you start to have a depression or bipolar, so a lot of electrical, going haywires and whatnot. So just put current, okay, and then we reset. Okay, it's just like resetting your handphone. Okay, so the question is, it is still used this day? Yes, it is. Okay, we only check whether the patient is a good candidate for ECT based on the first trial. Okay, we will do first trial. But like I mentioned earlier, ECT can cause temporary memory loss, and to some extent, they will start to erase all the life good memories. Like for example, the day of you having your weddings, okay, and then the day you had your very first vacation abroad, okay, these will be the things that you have to worry, or the psychiatrist worry. You start not to remember your birthday or even your wedding days. That will be very bad, right? Okay, we want to have good memories, but ECT can cause that. However, the immediate side effect for ECT will be temporary memory loss. Okay, maybe they forget about the before the session, whatever things happening to them, they cannot remember again. Okay, but after a few hours, then they start to come back. Okay, meaning to say memory doesn't loss, but it's only temporary. Okay, is there any age restriction and time limits? Yes. For children, we don't use ECT quite frequent. Okay. Usually we reserve for adult. Okay. Or teenage. Okay. But time limits. Time limit. Yes. It doesn't have to be 24 hours. Okay. It's only like 1 or 2 hours treatment. So it will be a short one. Okay. A very short one. Okay. We don't put a current very very long. Okay, maybe less than 10 minutes and whatnot. Okay. Okay, so Azanurin again, Ainurin again, like how many times one person can take? They can take, sometimes the psychiatry prescribe for ECT like 1 to 3 sessions, depending on patient response. If the first trial is unsuccessful, meaning to say that the patient start to develop all these, memory loss, headache. Okay, headache is one of the common side effect for ECT, and they cannot tolerate to this side effect, then the psychiatry will start to deprescribe, okay, ECT straight away. Okay, so it depends on the individual. So how many times? If the patient is, giving a good response with ECT, then the psychiatrist will keep on go up to 6 to 7 sessions. Right? Did I answer your question, Azza? All right. Okay. Okay. Thank you very much. Okay. So ask me more.
Sir,
Yes, Munir.
how does the long-acting injections actually being accepted? Like, do people opt for that, or the doctor just prescribe to them?
All right. Good question. Okay. So like I mentioned earlier, LAI or long-acting injection is actually reserved for those with non-compliant issue. Okay, so we don't really frequently prescribe LAI because they are very expensive in the first place. So those with, after taking several medication, okay, oral tablets, okay, and not taking, and then readmission to the ward because aggressiveness, okay, start to make disturbance, okay, in the community, keep on readmit to the ward, okay, in the psychiatric ward, okay, and then try to kill people or kill himself, okay. Now we come to the conclusion that the patient is actually non-compliant to oral tablets, okay. So in this case, the best approach will be opting for long-acting injectables, okay. And the problem with LAI is that the patient and the family members, okay, must bring that patient to the psychiatric clinics, okay, to get that injection once in a month or maybe every 2 months, okay, depending on the drugs, okay, half-life. So in this case, your question is actually, again, is it frequent or not? It is very rare, okay, but we do have patient with LAI injection in our psychiatry department. Yeah. Mona, did I answer your question, or do you have any more question for the question?
Yes, sir.
Yeah.
You answered my question. I have second one. For ECT and can be combined with the pharmacology.
Yes, it is. Okay. Usually, the psychiatry will start with the single medication monotherapy first. Maybe they start with pharmacological first. Okay. However, uh, it is a good practice to combine together with non-pharmacological therapy, particularly the psychoeducation, where we involve clinical psychologists, a talk therapy. So in this case, your question is actually, do we combine ECT together with monotherapy antidepressant or whatever, bipolar treatment or lithium? The answer is yes or no. Okay. Uh, Whenever the psychiatrist started monotherapy with oral tablets, okay, and the patient is non-responsive, okay, so psychiatrists start to prescribe ECT, okay, at that point, because it is very important to resolve all the symptoms straight away, because we afraid of the patient is killing themselves, okay, suicides, okay, attempt is there. um, well, some people or some patient might have only monotherapy oral tablets, but some people might need ECT in combination together with the psychotherapy. Okay, whatever it is, all patient will be advised, or it is a good practice to start together with non-pharmacological treatment straight away. Okay, but since ECT has some of the side effect which is very bad, like headache, memory loss. Okay, so we try to keep it first. Okay, with the oral tablet. Okay, if it is non-partial or non-respond or partial respond, then we start to add the ECT. But again, based on CPG, you can always combine together straight away in the first day. Okay, Munir, did I answer your question?
Yes, sir. Thank you, sir.
All right.
Last but not least, sir.
Yes, yes.
If the patient doesn't want to receive treatment, then we cannot do anything.
Well, yes, this is a ethical question, okay? Of course, because psychiatry patient, they don't have what we call it mental or cognitive capabilities of deciding the treatment. So in this case, if the patient refuse to take the treatment by the psychiatrist, usually we do have consent letter, right, or forms, okay, where the family members can sign on behalf. So, in fact, most of the psychiatric patient, we will have family members to consent before we start the medication, because the patient itself is no longer have the capabilities of deciding, unless they are still mild or still have thoughts of helping themselves. If you have a very aggressive psychiatric patient, then they might refuse to take medication in the first place. So in this case, whenever we get consented by family members, because family members, they are the one that living with that psychiatric patient, right? They are facing all those bad things, okay, done by that psychiatric patient. So they might need helps from psychiatrists. So they could be giving consent to treat that particular patient. So if it is consented by family members, if not, or if the patient itself refuse to take medication, then it should be okay. Okay, we get consent from the family members and start the treatment immediately. Did I answer your question, Munir?
Yes, sir. Thank you, sir.
All right. Okay. So we do have more question on the chat box. Okay. Question from Azrael Hakimi. Sir, can the patient develop tolerance to certain SSRI or antidepressant? Well, this is a good question. Okay. The issue with tolerance, yes, we do have one or two cases, a very case where this it's not like tolerance. It's more like non-responsive. Okay, it could be due to some genetic factors or pharmacogenomics perspective, okay? But in some patient, whenever they have some genetic polymorphism, okay, they might, it's like, pharmacogenomics, okay? Because pharmacogenomics also play very important parts in psychiatric treatment for all, okay? For all psychiatric treatment. To answer your question, Azrael, okay, yes, it can develop tolerance, but usually we will see straight away from the first day or first week, okay, or even the first 2 weeks, because we will do monitoring. To yeah, it depends on genetic polymorphism. We have to do genetic pharmacogenomics testing for this particular patient if the patient is having tolerance. But we can always opt for other alternative that might help the patient, okay, in terms of treating the psychiatric disorders. Did I answer your question, Azrael Hakimi? All right, okay. Azrael Hakimi say yes. Okay. Okay, next question is from Nur Adeline Shahira. Okay. So, is long-acting injectables antipsychotics has more severe side effect compared to oral routes or not? Well, this is a good question. Okay, it comes back to the knowledge of pharmacokinetics and pharmacodynamics. Okay, let's think like this. Okay, for oral, it has to go through first pass metabolism, second pass metabolism, right? It will have much more what we call it general or severe side effects. Okay, because it go through all the system in the body. However, injection or injectables, okay, it already passed the first pass metabolism, so it's straight away to the systemic, okay. But in terms of the numbers of side effect, I believe that injectables will have lesser than the oral because it doesn't, go through a lot of organs, but it still have side effects anyway. Okay, so did I answer your question, Adeline? Just a thumbs up to respond. Okay, next question is from Azhar. Any potential permanent damage to brain with ECT? Like I mentioned earlier, just now, ECT can cause what we call it, old memories loss. Okay, if it is being used continuously. So in terms of permanent brain damage, it could, but usually whenever the patient already gone like 6 to 7 session, then most probably would be, deprescribed by the psychiatrist, okay? We don't use it continuously, okay? If patients start to develop what we call it memory loss, okay? Permanent memory loss, okay? So did I answer your question, Azhar? Thumbs up if yes. If you have further question, then just put in the chat box, okay? Siti Zubaida, okay? So, since bipolar type 2 show more dangerous approach to suicide and all, is the treatment in terms of medication or other lifestyle management more details than bipolar 1? Well, they are not, okay? In fact, it is similar, okay? Similar to bipolar type 1 and type 2. The only things that we have to focus on in terms of reducing the risk of suicidal completion is actually to have what we call it psychoeducation with the family members and the patient itself. Okay, so talk therapy will be much easier to be done. Okay, sometimes we try to encourage the patient to to get socialized. Okay, so all this non-pharmacological therapy will be very helpful in terms of keeping the patient alive, okay, throughout the treatment. All right, so again, your question is, do we need a more detail? No, we don't. It will be much more similar. All right, okay. Siti Zubaida, thumbs up if I answer your question. Mama Azril, yes. Okay, no, I didn't. Yes. All right. Any more question, please? You can ask whatever question you like. Okay. Regarding of major depression, mania, or bipolar. All right. Question from Aida Zulaika. So, just a thought: what would happen, or what should we do if stock shortage occurred of medication related to this topic? Wait. So, just a thought: what would happen, or what should we do if stock shortage occur of medication related to this topic? Okay, meaning to say, okay, your question is, we work in the pharmacy and then suddenly we don't have that particular medication, right? Okay, for that psychiatric patient. Meaning to say that patient must take the medications continuously. Otherwise, the symptoms will come, okay, and harm the patient, all right? So in this case, as a pharmacist, we have to call the nearest pharmacy, okay, at hospital or the community pharmacy, whatever, whether they have the similar drugs available in their facilities. Okay, if they have, then we have to purchase. Okay, as a pharmacist, we have to have that medication available in our facility, so we have to go and purchase. Or in some cases, we request the patient to purchase using their own money, okay, outside. Okay, usually we will have in terms of locating which premise have that medication available. Whatever it is, we cannot, simply say, oh, we don't have that medication, and then you can, you can find, you can stop the medication or the treatment. No, you cannot. Okay, whatever it is, you have to talk to the psychiatrist. Okay, if we cannot find any of the medication available in other areas, okay, then we would like to, talk to the psychiatrist, telling that that particular medication could have problems in terms of imports or stock worldwide. Okay, so we will discuss with the psychiatrist whether we need to change to another alternative which available in our pharmacy. So did I answer your question, Aida Zulaika? Thumbs up if yes. All right, Fatima Shahira. Mat Yazid. Okay. So how long is an episode of mania or hypomania? Well, this doesn't have any exact time. Okay. It will be vary from individual to individual. Okay. It could be as shorter as a few days, or it could last for a few years. All right. However, for mania, okay, mania, I believe, I believe it will be in average, it will be a few weeks. Okay, a few weeks most of the time. Okay, but some people might have months. Okay, so that could be the answer that I can give, because people are different. Okay, they can be shorter, they can be rapid cycler, they can be long cycler. Okay, so it depends on the patient. Okay, but majority will be majority will be long cycler. Okay, as compared to rapid cycler. Okay, did I answer your question, Fatima? Raise your hand. Okay. Okay, ada Zuleka, understood. Okay. All right, Fatima Zuleka. Okay, Liana Suraya. Does abuse and dependency of medicine common in BD? Well, it depends. Okay. For the medication abuse, okay, we don't have medication abuse in most of the psychiatry, because the psychiatry patient itself doesn't want to take the medication in the first place. They usually have what we call it non-compliant issue most of the time. Dependency, nope. This is a very different than the case of pain control. Okay, pain control, whenever we prescribe with opioids. Okay, and in the case of, if you are a fans of Dr. The movies from Hollywood, I can't remember that particular medical drama. Okay, they abuse opioids. Okay, oxycontins and whatnot. So that is actually very common. But in the case of bipolar, we don't have drug abuse or even medication abuse or dependency. Did I answer your question, Diana Suraya? Raise your hand. Okay. So Munir again. Okay. Question. All right. Okay. Thank you, Liana. Okay, so since the medication possess narrow therapeutic windows and require TDM, will we get exposed with TDM later in lecture or flagship? Yes, you already learned this basic pharmacokinetics in your pharmacokinetics paper, right? In fact, some of the pharmacogenomic aspect will be covered in pharmacogenomics courses. You don't have to worry. We try to really focus in PHC690 only for clinical aspects of the treatment. Okay, so you will undergo all these pharmacokinetics and pharmacogenomics courses later on, if not previously. Okay, in lecture or in clerkship? Yes, in lecture, in other courses. In clerkship, you have to gather all the information from these three different courses, okay, clinical papers, pharmacogenomics papers, and pharmacokinetics papers, and then you have to consolidate all this knowledge in your clerkship, okay, for case discussion. All right, did I answer your question, Munir? Please raise your hand. All right, okay. Any more question? We still have 30 minutes. Well, the celebrity in Malaysia that have bipolar will be, anyone can tell me their name?
Janani.
Okay. The queen of Malay dramas nowadays. Okay, the one of the the winner of Anugerah Juara Lagu, I guess. All right, and then the other one with the cat one, topi beras. Okay, all right. Okay, so sir, question from Azrael. Sir, is there a case of patient with MDD abuse other drugs such as tramadol for its euphoric effect? That is a very good question. Well, this could be individual case, okay? But in general, MDD usually don't abuse drugs quite frequent, okay? In fact, if they want to purchase tramadol, it is actually prescription medication. So it is not easily accessed, okay, to this kind of tramadol. So I believe that it is very rare to see patient with MDD to abuse drugs, okay? Unless they are drug abuser in the first place. Meaning to say that they are drugs addicts. Remember, some of the causes of mania, depression, okay, it is actually due to drugs, okay? Drugs, I mean illicit drugs, okay? Narcotics and whatnot, do drugs, okay? Or even chemical substance, which is synthetically manufactured or produced. So those, I had an opportunity to visit what we call it PUSPAN, Pusat Pemulihan Narkotik, which is our drug addicts rehab center. These drug addicts, if they already like adults, okay, but they start to abuse all these narcotics, okay, illicit drugs, maybe since teenage age, okay, okay. So what we can see is that they have a drug abuse problem in the first place, okay, and they also start to develop all these, psychosocials, okay, or psychosis, depression, or even bipolar. Okay, they start to have psychiatric disorders. So please do not abuse drugs, okay, because these drugs will damage your brain, neural networks and whatnot, chemical balance and whatnot. So most of the time, drug addicts will sooner or later develop bipolar, depression, or even mania. All right. So to answer Azrael's question, is there a case of MDD abuse drugs? No. But if they are drug abuser, they will develop MDD in the future. Okay, question. Thumbs up, Azrael, if I answer your question. Okay, Dini Najiha. Does a patient usually not aware when, thank you, Azrael, not aware when they are in a manic episode? Well, they don't, okay? Because, in fact, we need somebody else to remind us, okay, in some cases, okay? But some who are very educated, they might realize that they are having mania. But most of the time, patient might not aware, okay? Otherwise, they will control themselves, okay? They are normal people. Only normal people are aware, okay? But those with psychiatric disorders, okay, being diagnosed with manic episode, they don't aware, therefore they keep on doing overproductive, cannot sleep, and whatnot. Remember, one of the example of mania would be, you start to be very happy, euphoric, okay? You start to go to the nightclub, okay, having parties every night, okay? Don't even sleep, okay? It start to impact your functioning, okay? You don't sleep, you keep on enjoying, okay, having fun outside, okay. So to answer your question, Dini, they are not aware most of the time, but for us normal people, we will aware, okay. That's different between having fun and mania, right? If we aware, then we will stop or reduce that, having fun, okay, and then we start to restore our social functioning. But those in psychiatry, they cannot aware, so they keep on doing, and then they start to impair their social functioning, okay. So Nurul Najiha, okay, asks, sir, can we use ketamine or esketamine in the treatment-resistant depression? Yes, we are, okay. I do not cover in this lecture slide, okay, but we do have what we call it esketamine nasal spray, okay. So this is a very expensive medication. One bottle, okay, for a few sprays can cost you like 20,000, 80,000 ringgit, okay. You cannot, afford, okay, to purchase this. But we reserve this esketamine nasal spray, okay, for the case where all the treatment fail to cure depression, okay. So this is actually esketamine. Esketamine nasal spray is actually very expensive, and it must be what we call it given at psychiatric clinic, not being taken home. It must come just like long-acting injectables. Okay. Did I answer your question, Nurul Najiha? Okay. Before we give esketamine nasal spray, we have to pick another alternative like ECT. Okay, the other much more cheaper option, because definitely esketamine nasal spray is very expensive. Patient can even afford unless they are billionaires. Okay. One Khairana asks, in the earlier slide, you mentioned that manic and hypomanic are not substance related and caused by other medical or psychiatric disorder. But in the latest slide, there are some drugs and medication conditions that induce mania. Is it the same or indifferent? Can you explain again? All right, very good, Wan Khairana. Okay, in fact, you need to really understand this statement. What I mentioned just now is that if you have mania because of you are taking illicit drugs, meaning to say you are drug abuse, then we don't, it will be temporary. Whenever you high, okay, you take illicit drug, you high, you feel mania, right? You want happy and whatnot, la 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 la, okay? But it will resolve, okay, after you stop taking that medication or chemical or drugs. Then we don't diagnose you as true mania. It's just because of that particular drugs, chemicals, all right? So, however, in the case of psychiatry, you have mania is because of the organic, okay, your brain itself, okay? It doesn't caused by the chemical or drugs, okay? So that is actually the similar explanation for other medical reason, okay? Other medical reason, like for example, if you have like, concussion, brain concussion because of motor vehicle accident, okay, and then you start to feel mania afterwards, it will be temporary. After your concussion resolve, then you start to feel normal again. So we don't call you having bipolar or mania at that time. Okay, it's just consequences of having other medication or taking drugs. Okay, so that is actually what easier to be explained. Okay, did I answer your question, Wana Khairana? Raise your hand, or do you need further invest? All right. Okay. Okay. So any more question, please? So whatever it is, okay, if we want to say or diagnose the patient to have bipolar or depression, we have to make things clear that the patient is actually having a true depression or bipolar, which doesn't cause by other consumption. Like for example, alcohol can cause mania as well because you start to feel, happy, euphoric, okay, and whatnot. But it will resolve after that alcohol being excreted from your body. So it will be temporary. However, if you develop euphoria, okay, out of nothing, then we start to take you to a psychiatry clinic or department. Okay, raise your hand if you really understand all the topics, okay? Okay, and then put confetti. Confetti, this is confetti. If you want to end the question. Okay, we have, did you raise your hand? Okay, Sophia want to end, okay? Okay, okay, good, understand, okay? Put confetti if you don't have any more question, all right? And we will end this session, okay? You can always ask me whenever you like, okay? Email me or contact me through WhatsApp whenever possible, right? So if that the case, then I would like to end the session and don't forget, yep, Mama Arif.
Sir, may you open the attendance back, please? Because there are some students that forget to fill in the attendance in the near future.
Well, sadly, it is set as, okay, never mind. I will create one more, okay? Because whenever I already said, it cannot be edited anymore. So it's supposed to be the last attendance should be taken at 10:15, okay? But I will create a short one, okay, where everybody must, pick again. Can you do that?
Yes.
May I know why some of you cannot? Is it forgetfulness?
Yes, because of the forgetfulness.
All right. Okay, never mind. In fact, I also forget this morning, okay, lecture, all right? Okay, so maybe I can create a Google form, okay? And then whoever forget, please take attendance through Google form. I will send through Arif, okay, the link, and then share with the others, all right? Those who haven't take, okay, on your future. Is that okay?
Yes, sir. Thank you.
All right. Okay. If that is okay, then I end this session. And sorry, we do have more question. Aida Zulaika asks, people diagnosed with MDD or mania, can it be cured completely, or the patient will have it until the end of time? Well, well, this is a good question. Okay. As a Muslim, we believe that we have all cure except for death and aging. Okay, so scientifically, we do found that patient with MDD or major depression resolve. Okay, resolve after several treatments. Okay, or several years of treatment. Same goes to mania. All right. But some might need lifelong treatment. Okay, in the case of bipolar, because they are already like malformed brain. Okay, because of genetic and whatnot, we found that some people need to take that medication or treatment lifelong. Okay, so to answer your question, some will resolve, or some even cure. Okay, but some still need to take that treatment lifelong. So that is the best answer for this question. Did I answer your question, Aida Zuraika? Right. Okay. So with that, I believe we end our lecture session today. And I hope that you can ask me more questions regarding of this topic in bipolar depression. Okay. I'll see you on 25th April, which is next 2 days, okay, for schizophrenia. Okay, the link has been shared with Arif, and those who haven't take your future, you have to fill in Google form, which I will send link to Arif very soon. All right, thank you everyone, and have a good iftar. All right, and have a good day ahead. Thank you, everyone. Assalamualaikum.
Thank you, sir.
Thank you, sir.
Thank
you,
sir.
sir.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
Happy iftar.
You too.